Welcome back to DASy 2020. For our next session, we're going to talk about nursing in dialysis access. Now I would like to introduce you our chair, Dr. Lin Ruixiang from Taiwan, and our commentator, Nurse Alice Su from Taiwan, Lilian Lo from Singapore, Nurse Xiao Naihua from Taiwan, and Nurse Chen Pei Xuan from Taiwan.
Okay, good morning. I'm the chair of the section. This section discusses about the nurse in dialysis access. And so let's start our session.
For our first speaker, let's welcome Dr. Lilian Lo from Singapore, talking about what is patient-centered dialysis center.
Ladies and gentlemen, good afternoon. I'm Lilian with Tor Dialysis in Singapore. I'm delighted to be with you today at DASy Online Conference. First, I would like to thank DASy Committee to put in such effort in such challenging situation COVID-19, continue make our day DASy 2020 happen. Today, my topic is patient-centered care in dialysis center. Let me introduce a bit ourselves. We are Tor Dialysis in Singapore. Tor means morning dew. It presents a fresh new beginning, the start of every precious day. We are at Tor, want every patient to look forward to the dawn of each new days as a new lease of life and be at their side to play a meaningful support role in motivating and helping them to go back their feet, carry on life is a fullness. Tor value is enhance dialysis nurse natural passion to build Tor person-centered HD center, the one place where dialysis patients feel right at home. Let me share with you what is person-centered care, what we did, why it is important. Person-centered care is providing care that is respectful and responsive to individual patient preference, needs, and values, and ensure the patient values guide all the clinical decisions. There are role changes in this transform. Patient in the past, they are witness and the recipe for the treatment, used to ask for taking care of, now become a resources, co-creator, responsible. As dialysis nurse, we are used to be care provider, practitioner, and firefighter. Now we are health helper, advisor, trainer, and preventer. Dialysis center used to be a visit place, specialized in the dialysis treatment. All information is controlled. Now become a place to build the continuous relationship, co-operations, empower place, and all the information are sharing. There are 5 strategies using in Tor. First strategy is communication. A person-centered care is a willingness to learn about the patient experience and what is important to them. The listening is a key. In Tor, we talk with the patient based on dignity, willingness, and responsibility. We use open-ended listening, utilize the patient resources and the needs. Every patient arrives Tor, we start up with Speak Out program. We teach patients speak out for their concerns, pay attention to their problem, educate themselves, ask questions, know what is happening, use resources, and participate. To understand the patient, we use this circle of health tool to quick exploring area of their life. Show them the circle and use it to facilitate a discussion. Explain their well-being. Health starts with the center me, who they are as a person, and expands outwards meaningful awareness. There are 8 areas self-of-care. Working with your body, surroundings, personal development, food and drink, recharge, family and friends, spirit soul, power of mind. To ask them describe who they are as a person and share what matters in their life. Strategy 2, making time. A shortage of time is one of the greatest barriers to delivery of person-centered care. A very interesting essay read in Enchanting Medicine, written by Dr. Lydia. She says, because I aim to care for my patient as a person, as a friend, the 15 to 20 minutes we spend together will never be enough. but as we grow in our understanding of one another, I can battle the constraint of modern medicine practice, knowing that my patient are on my side. We are in it together. Another interesting book, God's Hotel, A Doctor, a Hospital, to the Heart of the Medicine. Victoria's Sweet Talk, How Healing Takes Time. In renal care, many of us actually have a privilege of caring our patient over years. Although we may not always have time to address everything of importance to the patient in a single visit, we can often pick up where we left off at the next visit. Third strategy with building relationship. As we know, professional boundaries are intended to strengthen providers' ability to care for the patient. Some providers will prefer to maintain emotional distance from their patients. In turn, we're looking for opportunities to get to know our patient as a people and for them to get to know us also, sharing aspects of our life and experience when we think this may benefit them. In this building relationship, trust is a foundation. It develops based on the mutual respect, honest, and clear communication, alignment on the care plan. The book, Medicine and What Matters in the End, author speaks from the personal experience about the patient-centered care is a willingness to try honest not only our patient's goals, but also their values. He pointed out we must decide how far and in what way we are willing to travel beyond our own area of expertise and training to support our patients. The fourth strategy, let's go beyond. As we all know, laughter is the best medicine. So in our center, we do the laugh yoga with our patients. There is also an interesting book written by dialysis patient. It's a cartoon book, The Lighter Side of Dialysis. This book is actually dialysis nurses encourage his patient to publish. The nurse felt it will be beneficial not only amuse the dialysis patient, but also help them better deal with their situation as well. So we can do thousands of others. Fifth strategy, engagement. Patient engagement to me implies active interest in the disease process, therapies, and outcome. It means that patient question on the tests and the recommendations to understand what is going on and how it affects their lives. It means the patient feel free to disagree with the recommendation and they're willing to have a discussion. I can't forget this doctor said, I have spent 20 years telling my patient what to do, and now I have to help them to find the answer themselves. They do it. Have some ways we engage patient to learn how is a dialysis-friendly food, and then sharing their missions and hopes. How is our person-centered care outcomes? In dialysis center, we usually measure whether we achieve up the 8 quality of care indicators. They are anemia, dialysis dose, bone metabolism, nutrition, vascular access, middle molecule removal, and hemodynamics. The information from core database suggested 3 quality goals are strongly associated with the person-centered care. They are KTOV, the dialysis clearance. In TOR, we adjust each dialysis session according to the individual patient's clinical status and preference. We have achieved 90% of our patients achieve KTOV 1.4. Secondly is consistent use of fistula. Quite surprised in the past, vascular access actually contributed to most hospitalization in our patient. And access thrombosis and dysfunction can contribute to the missed dialysis treatments. So we actually after implementing the patient's centered care, this is much improved in the data. The third one is good nutrition, especially in the albumin data. Let me introduce how is our person-centered in dialysis access care. We call it the art and science of cannulation. We reinforce a good, encourage sharing experience from patient and nurses. We also ask the patient to encourage patient engagement. We do the dialysis access education, and then we share the stethoscope, listen the fistula together, check decide the cannulation point with patient together, and discuss before and after vascular access review in hospitals. Physical cycle aspects. We match the cannulators and the assessors, usually the more experienced nurses. You will needle the new fistula, and then the difficult needling, attending those buttonholes. Every needle looks is very precious, and then we take time, and holding our patient hands gives support. We also give the comfort cushion for 4 hours dialysis. Here is our patient's voice. I have a patient 72 years old. He's telling us, my dialysis nurse talked to me like a person. It made me feel normal, almost healthy. Another patient, 68 years old lady, she said, I try to listen to my body. No doctor knows it like me, so they listen to what I tell them. A young patient told us, 48 years old, I now feel I can manage my health independently, except in a crisis. However, I don't think this is recognized. I'm still requested to go back to the hospital every 6 months for an appointment. That may not needed. Hospital doctors should be focused on the patients that need more support than me. I want to create my own care plan, content goals setting, and measure myself. I don't want to spend time in hospital clinic to manage my health. I want to do it in the way like our banking, shopping online, so that I can achieve and update my own plan. There are always challenges in the achieve person-centered care. It will be difficult, but not impossible. Look at this beautiful drawing chart. This is we use for training the nurses and sharing with the nurses how is a person-centered care. We start with a dream, and then we start with the dream and understand the patient's family and the key people are surrounding them, and then the patient will give us the value and elements. Then protect question, that is the way of the protect question dialogue. We find out the content, and then conversation starts. Conversation starts with a skill and interest. Then sharing the dreams, and then the team process. How we approach a team process, support each other, and then give the honor without the judgment. Then brainstorming all this, and then achieve to execute the actions. Listen from our dialysis nurse's voice. The patient-centered care can be in very simple ways. Make a difference by smiling, by a warm welcome, a warm send-off. Provide the patient with a place where they feel welcome and they feel like they are going to get healed rather than the treat. I hope this topic is useful for you. I hope to see you in the next DASy. Thank you.
Okay, thank you for Lilian Law from Singapore speech. So let's start our next section is the Chen Ju Hui. Okay.
For our next speaker, let's welcome Nurse Chen Zhou Hui from Taiwan, sharing about the impact of frailty on the outcomes of hemodialysis vascular access.
Good morning, everybody. I am Zhou Hui Chen. Today, my topic is the impact of frailty on the outcomes of hemodialysis vascular access. First of all, I would like to introduce frailty through this picture. Frailty, a form of geriatric syndrome, is often accompanied by decline in overall function and multiple organs. Frailty is prevalent among the patients on dialysis, and they have health problems such as decline of physical function, loss of muscle mass, and fatigue, thus making them vulnerable. Frailty is a multi-dimensional concept that is affected by complex interactions between many physiological, psychological, and social factors. like age, environment, and some cognitive factors, will affect frailty. Talking about the assessment of frailty, we will use the most conventional method, the Fried's 5 criteria, and it consists of unintentional weight loss, grip stress, exhaustion, physical activity, gait speed. If a person doesn't match any criteria, he is called non-frail. If a person meets 1 or 2 criteria, he is called pre-frail. If a person meets 3 or more criteria, he is called frail. This method shows dynamic and continuous nature of frailty development. If the frailty becomes worse, the patient will have a higher mortality risk. Next, this study shows that the prevalence of pre-frail about 45% among the elderly, and the frail is about 10 to 50%. And we can see that the prevalence of frailty among patients on dialysis is 26 to 73%, and it is over twice of the non-normal elderly. Frail renal patients usually have these phenotypes, such as fractures, body composition changes, and so on. Moreover, they will also have a higher possibility of mortality and hospitalization. And today, I want to focus on the vascular access failure of frail patients. Next, I will talk about a clinical study on frailty and vascular access failure. This study was conducted in a hemodialysis center. There were 270 participants, and it lasted over 50 months. In terms of research method, this was a prospective observational study. We use frail score as exposure variable. Outcomes variable is vascular access events, and confounding variable contain age, Charlson comorbidity index, vascular access type, and sex. The prevalence of frailty was 38%, and it was twice of normal elderly population. Most of the patients had poor physical function, followed by low vitality and albumin levels. Now let's see the baseline demographic and the biochemical data. There was no correlation between the months on hemodialysis and AV fistula use. It was correlated with elderly, female, comorbidity, anemia, and poor nutrition. This chart shows distribution of access type by fail status. In our study, 80% of patients use fistula, 50% use AV graft, and 5% use painkillers. About 25% of failed patients use graft for dialysis, and only 10% of non-failed patients use graft. It was nearly twice the number of non-failed patients. In the 2 years follow-up period, 35% of failed patients experienced thrombosis of vascular access. In contrast, only 22% of non-failed patients experienced thrombosis of vascular access. In other words, failed patients had 15% higher risk of vascular access thrombosis than non-frail patients. And next is the table of access failure and mortality. After 50 months, the frail group had a 23% mortality rate, while the non-frail group had an 8% mortality rate. Overall, frail patients had a 70% increased risk of access thrombosis than non-frail patients. When confounding factors such as age and sex were adjusted, only the component factors of decreased physical performance significantly increased risk of vascular access thrombosis. In conclusion, frail hemodialysis patients have a higher risk of vascular access thrombosis. Further studies are warranted to investigate the effect of strategy to improve frailty on outcomes of vascular access. This is the end of my topic, and thank you for your attention.
Okay, thank you for the Chen Qiuhui impressive topic about the frail hemodialysis patient compared with non-frail hemodialysis patient. We will discuss the question later. So let's next the speaker is the Tai Li Hua. He discussed about the effectiveness of physical exercise during the hemodialysis room.
For our next speaker, let's welcome Nurse Cai Li Hua from Taiwan, sharing the effectiveness of physical examination for vascular access in hemodialysis room in Qimei Hospital.
Good afternoon, ladies and gentlemen. I am Li Hua Cai. I work at Qimei Hospital, Jali. I'm a hemodialysis nurse. I'm here to talk about the effectiveness of physical examination for vascular access in a hemodialysis room in Qimei Hospital, Jali, Taiwan. Today's presentation will be given in 6 parts: person background, situation analysis, plan, result, conclusion, discussion. First, personal background. I had 142 patients in Qimei Hospital in Jali in 2015. Now I have 174. 90% use hemodialysis therapy. We had 3 types of abscess. First was the AVF, second was the AV graft. 90% use these 2 types. The others use central vein cast. The patient vascular access is often referred as their life and result. The life-sustaining treatment or hemodialysis will not be possible. To maintain the access, accuracy, and the activity and the timing interventions. This bar chart illustrates the carry-out PDA from June to December 2015. Number of people was 26. Delay were 18, and on schedule only 8. This is a bad situation. I would like to say a story. One day, I told the patient that the vestibular function was not good. But the patient said to me, "Only you say that. The other nurses say no problem." So that's why I say, when the nursing assessment is inconsistent, the patient will not try anything. Situation analysis part 1. This is a table shows fistula function assessment before referral. It was from the data assessment from was incomplete, and the saturation population where is the top 3. Our lines from the list there were lack of knowledge. For example, knowledge of fistula maturation, lack of skill profession. For example, the nursing doesn't know how to differentiate population. Also, lack of appropriate assessment tools. For example, there is only a stethoscope, which is not easy to assess. In this table, we can see a nursing staff knowledge scope, population and orchestration rules. A range scope 63.5, 63.5. This result is bad. In the last table, we can see the accurate fistula functional assessment. Potential and oxygenation assessment techniques worse. Average rate was 62.5%. It was also not good at all. Next slide with some praise. Plan, lack of knowledge. We provide a combinational training and combination perform. Plan, skill progress. Best citation one by one. Appropriate assessment tools. We develop a standard assessment tool. Evaluation guideline. Let's look at the assessment tools. Assessment tools. Position with finger. Best score is 1 to 5. 1.1% position and heart vessel. 2.75% position. 2.5% 3. 3.15 position, 15.3, 4.75% position, 25 third, 4.3 strong. If the patient position is only 3 points, and the clinical sign and the symptoms of AVS dysfunction are such as thin as Miller's place is greater than 2/3 of the flow rate, difficult communication, and molestation, you can refer the doctor. These are some results of nursing staff knowledge score. We have improved. The projects have been implemented. The fistula assessment awareness score increased from 63.5 to 93.6. Accuracy of fistula functional assessment improved from 16.53% to 96.6%. The bar chart induced that care of PTA from June and December 2018 to 29. We can early distinction and referral. The early treatment of fistula abnormality improved from 31% to 89.6%. These results show the occupational training, clinical operation guideline, and routine monitor can effectively improve the accurate nursing staff through gaining the acceptance of the dialysis patient under quality fistula care. Discussion. In the future, we can create and establish a complete fistula assessment program to strengthen clinical practice. Take rule from the production, spare from hemodialysis training course to various dialysis centers. Standardize the assessment of fistula function through the revisit of the nursing associated rule, the assessment tools. That's all. Thank you for you listen to my presentation. Evaluation of vascular access is very important. When the nursing assessment is inconsistent, the patient will not try anything.
Okay, thank you for the speaker Chai Li-Hua bring us the importance of the assessment tool of the nurse, how important it is. So the next topic we will speak about the instance reporting system. Okay, let's welcome for the Tiffany Chang.
For our next speaker, let's welcome Nurse Tiffany Chang from Taiwan. Her topic is the experience of establishing safety culture for dialysis access care in Taiwan.
Good afternoon, ladies and gentlemen. My name is Tiffany Chen. I have been working at dialysis field for more than 20 years. Thanks for the invitation of the Congress. I am greatly honored to share my experience at this section. I would like to talk about how to establish safety culture among dialysis clinics for dialysis access care. There are some safety fundamental requirements for dialysis treatment need to be addressed in dialysis unit, includes but not limited to medication management, emergency preparedness, incident and risk management, equipment and facility management, security and environment control, aggressive behavior management, occupational health and safety, vascular access management, and infection prevention and control. I'm not going to go through each detail. I will only focus on vascular access management. A dialysis center is responsible for the quality, safety, and care provided to patients. Of all, safety of dialysis access is one of the key parameters affecting the outcome. For clinical staff who does not work at dialysis field, dialysis is viewed as a mechanical process, which can be performed without much attention. But we all know it is not true. Access to dialysis is a risk factor for safety issue, potentially affecting the patient's outcome. To address the specific risks, we initiated the Vascular Access Learners program in our organization. We use the approach to help physicians and dialysis staff work collaboratively to value safety as a primary goal, develop specific competencies in safe practice, create patterns of behavior, or practice that foster patient safety, and measure the effectiveness of preventive measures. The program aims to provide relevant guidance to staff regarding the vascular access monitoring and cannulation procedure. By refresh and enhance staff's knowledge and skill, such as basic vascular anatomy, consideration for vascular access creation, vascular access complication, and etc. And the dedicated vascular access learners who are responsible to collect data of routine dialysis access monitoring and surveillance. He or she also responsible to undertake annual competency check for clinical staff and organize vascular access education to staff if needed. Hemodialysis treatments are highly complex. Caring for patients with multiple risk factors that predispose to errors. We all know error in dialysis care can cause harm and death. The cause of potentially preventable complications leading to death and dialysis unit work, recognition and treatment of hyperkalemia, medication prescription issue, care after hours, and prevention of infection and management of vascular access. Some study has suggested that effort to improve the safety of renal replacement therapy should focus on the human factors involved in care, rather than focusing only on the technical aspects. These concepts apply to dialysis access management as well. You can see on the side, this is the online incident reporting system that we have in our organization. Reporting incident is essential since it raises the organization's awareness about the things that can go wrong so that corrective and preventive action can be taken promptly. Without the communication channel provided by incident reporting protocols or system, a variety of threats to safety could go unnoticed and unresolved. Here you can see some example of the incident that we need to reporting within our organizations. The category that related with vascular access, such as neuropathy, infiltration, hematoma, hemostasis tie, infection, inflow stenosis, outflow stenosis, and recirculation. The reason why we ask our clinical staff to report this kind of event is that we like to promote the opportunity to correct the cause and prevent future complication. In terms of maintain the longevity of vascular access and improve dialysis effectiveness. Policy and procedure are an essential part of any organization. Together, policy and procedure provide a roadmap for day-to-day operations and practice. They ensure compliance with laws and regulations, give guidance for decision-making, and streamline internal processes. To have a systemic and consistency of clinical practice across clinic, we have policies and procedures are developed and taught to dialysis staff to prevent errors and keep patients safe. Nonetheless, clinical staff sometimes ignore or are unaware of policy and do not follow procedures as requested. Engaging a clinical audit can help understand why this is happening in a dialysis facility and suggest mechanisms and action to correct it. Standardization is one of the approaches to reduce potential error. For example, venous needle dislodgement is one of the most serious adverse events that can occur during any hemodialysis treatment. We instruct our staff perform prevention strategy, such as risk assessment and control, standardized tapping method, securing the brown lines, machine position, pressure monitoring, and appropriate alarm limit setting, and encourage maintain access visibility at all times. You can see in a slide that we implemented a standardized approach, the 7 techniques. For taping the needles and brown lines, which is highly recommended by many authors and professional groups. As what I mentioned earlier, hemodialysis treatments are highly complex, caring for patients with multiple risk factors that predispose to errors. Each dialysis staff are responsible for ensuring the quality and safety of care and for fostering a culture of patient safety. It is therefore important that staff understand the sources of risk to dialysis patients and champion process improvements to keep their facilities safe. Dialysis organization should establish and maintain a culture of safety in which all staff members are encouraged to report error or potentially harmful events in a blame-free environment, without fear of punishment. An implemented continued quality improvement program within clinic to close the gap and make our clinic a better and safer place for dialysis patients.
Okay, thank you for Tiffany Chang give us a wonderful speech about the instant reporting system and discuss about the advantages. So the last speaker is Zhang Yu Zhu. She will discuss about PD in National Taiwan University about patient education.
Next, let's welcome our next speaker, Nurse Zhan Yujun from Taiwan, talking about new patient education model in PD of National Taiwan University Hospital.
Hello everyone, my name is Yujun. I am from Taiwan. Today I'm going to talk about our new patient education model in PD of National Taiwan University Hospital. First of all, let's take a look of our operation model, which we followed every day here. Whole process begins from pre-dialysis education, through catheter implantation, to new patient education, and monthly follow-up. When CKD patients enter stage 4 or 5, our nephrologists would make a special appointment for them. Doctors and nurses would introduce every renal replacement therapy in this pre-dialysis education class with leaflets and videos. Patients were encouraged to ask any questions that they concerned. After pre-dialysis education, if the patient chooses to do PD, they would undergo a surgery to implant the Tinkoff catheter. PD nurses would work with our surgeon to make sure the function of the catheter. Then, they will be discharged in 4 days. In order to improve healing, usually it takes 2 to 3 weeks before starting PD therapy. We would let the patient and their family come back to PD room to start PD training during this period. Training topics include orientation about hospital environment, patient rights, safety, hand washing, and pain control policy. Also, skills about PD solution exchange, wound care, diet and nutrition education, medication education, emergent incidents, and other important instruction for doing PD at home. We would provide patients a schedule of training process. It is also a checklist for primary nurse to see if patient achieve the basic standard of each item, so that we could regulate the training speed accordingly. Usually, we teach practical skills before heading to knowledge list here. However, some of our patients could tolerate uremia symptoms for even a year after catheter implantation. In this situation, they would just come back monthly to review their skills. When the day comes, we could start to teach them all the knowledge they need to know then. In order to get a successful training outcome, we provide quiet and private room for our patients and try to create a warm and bright atmosphere by managing colors and lights. In our fluid management room, there is a camera to help monitoring patients' practice and keeping their safety as well. For teaching quality, we emphasize one-on-one teaching style. Every patient has their own primary nurse to help them handle all the training stuff. For patients with good social support, we acquire their family members to learn together. Sometimes we need to teach their foreign caregivers as well. In Taiwan, a lot of home care service were provided by migrant workers coming from countries in Southeast Asia. So, we also prepare multi-language leaflets to teach them. These are all the useful tools for giving a good training course. We have well-structured instructions in not only Chinese, but also in English, Vietnamese, and Indonesian for foreign caregivers. There are videos and pictures for skills learning too. Patients could watch particular clips repeatedly at their home to reinforce their memory. With the help of bigger pictures focusing on details, they could learn more easily step by step. For demonstrating the skills, we use little model to show patients how to change PD solution and perform wound care. Patients could also use the model to practice before really doing on themselves, including automated peritoneal dialysis machine. For tank-off catheter care, important details were highlighted in posters with these 5 no rules here to prevent infection and improve catheter safety, such as no scratching or bathing for preventing wound infection, no compress or pulling for reduced risks of granuloma formation. These are all based on real situations that happened in our units before. In order to increase training accessibility, we set up a QR code system with educational resource. Patients could use their smartphone to review these skills at any time, any place. Before starting home PD, all essentials were listed in a paper. PD nurse would explain the reason why they need to prepare certain things and the correct way to use and store them. Emergent events like peritonitis, hemoperitoneum, catheter rupture, and so on were illustrated. Patients need to know how to deal with these situations in advance to prevent panic at home. Early detections of signs and symptoms by themselves were so important for timely treatment. This also reinforces their confidence of caring themselves at home. To enhance patients' sense of security, we provide 24-hour telephone consulting service. On weekends, holidays, or even at nights, they could have a reliable helping resource when they have problems doing PD at home. We'll record the events and hand it over to their primary nurse. There are 460 patients in our center so far. Averagely, 35 phone calls were answered every month last year. When they come back for monthly appointment, primary nurse would assess their nutrition and fluid status firstly, and check wound condition before they go to see their doctor. Giving diet education and discussing solution adjustment with patients are largely depending on PD nurses in our center. That's how we cooperate with our nephrologists. Once the patient starts to enter long-term PD therapy, all patients and their main caregivers have to take a retraining course every 6 months, including knowledge related to peritonitis and exchange technique as well. For patients with peritonitis, We increase retraining frequency at first and 3 months right after peritonitis happened. In this way, a deep impression of peritonitis prevention was made on them. And the PD customized electronic medical system, which is called PDS in our hospital, also helps us a lot in patient management. Here is an example. When we retrain a patient, the result of our assessment in environment preparation, exchange skill, and knowledge aspect could input the system. The data could then output as a report, which could make a comparison of previous performance more efficiently than before. And another special course is our outdoor education. We used to invite our patients to have a one-day tour with us every year. We would teach them things they have to notice when exchange diarrhea outside their home. During prized quiz time, some important issues like low-phosphate diet, fluid control, and peritonitis prevention would raise up. From their feedback, this actually helps them build their confidence in traveling a lot. And this is the end of my speech. Thank you very much.
Okay, thank you for Zhang Yu Chu, the speaker, give us the discuss about the patient education in PD. A while ago, we getting the questions from on the net. Okay, is any problem from computer? Okay. Oh, please, Lilian.
Hey, hi. Can I hear you? Can you hear me? I'm Lilian from Singapore.
Yes, we can hear you.
Okay. Thank you very much for all the sisters sharing the Taiwan experience. I should have a great learning from yours. Yeah. So for my question is, I'm quite impressed in the guidelines, clear guidelines and workflow to refer patient. When is the nurses to refer patient back to the surgeon or vascular access team? So I know how is the work out, how accuracy of the, if you refer patient to the hospital will do the actions, the doctors recognize, the nurses refer patient is accuracy.
Okay, thank you for your questions. Because we practice in Taiwan, once we get in the problem, we will also refer back to the surgeon, right? But however, we have the connecting systems. Many hospitals, we have the special person to get in our problems. Then once we just contact them, after the surgical intervention is done and the patient is discharged, so the patient will be referred back to the center. Dr. Jackie, please.
Mr. Chairman and Pei, may I suggest in this section, because I see a lot of sisters in the dialysis center here, maybe if we can switch to Mandarin for a short period of time, so that they can express themselves much fluently. I'll be happy to just translate afterwards.
Okay, thank you for your suggestion. 所以我们是要用中文直接讲也可以啦。
非常好，非常好。刚才Lilian的问题，大家有没有什么回应？Lilian的问题是，当你们用你们的那个很好的系统。把病人转介回去外科医生那边，因为你觉得他的那个血透通路有问题，那回馈是怎么样？是不是绝大部分你们转介的病人都受到治疗？有没有就是一个沟通，就是他们做完了之后怎么样去回馈给你们那个 feedback？
这个问题很好哈。其实我们诊所跟洗肾室，跟洗肾室或者是外科这个部分，我们在转介病人，通常我们会善于利用那个转诊单。转诊单上面我们会很明确的写这个病人平常的状况跟这一次发生的问题是怎么样，然后请病人把这个转诊单就是过去门诊的时候给外科医师。那外科医师了解病人的状况之后，有什么建议啊，或者会做什么处理的时候，也会写在这个转诊单的里面，然后再回馈过来给我们诊所端跟洗肾室端这样子。
I just make a small, short translation for the audience that are online and also over the Zoom. So Pepe just replied that they will have a notes to write down what are the features of the dialysis access that they are feeling worry to the surgeons. And then when the surgeons treated the patients, they will also come back with a memo about what are the treatments and subsequent things to look after.
May I also have a questions to Sister Tiffany? Actually, I saw they have used the management system. They actually qualified the vascular assessment risk to the risk management. This is I totally agree. It's very good. So I wanted to know this system is called QRMT. Is it accessible by nurses or only management? 我的问题是我看到Sister Stephanie 她有一个很好的 system to 就说可以继续病人怎么样记录病人的那个 incident report risk management report 这个是护士可以用的呢还是只是那些management 可以用的是 nurses 可以直接写在里面的吗
Yes, we provide user account for each staff so they can input the incident if there's any incident related to vascular access or even complication during dialysis or related with operational or occupational health or safety. They all can input the incident by themselves. So it's an online system, and so they can, if they have the computer, they can report the incident anywhere they want.
Oh, this is very wonderful. Thank you very much. I think we can implement this system also. Thank you.
Welcome.
Sister Tiffany. 我带那个岳主任问一个问题the question is the system that you show is it a commercialized system that the dialysis center bought over to install or develop from your dialysis center 问题就是你们一个本来的系统买下来还是自己研发的
It's not a commercial system. It's developed by our Fresenius Kidney Care, so it's not open to external. It's only used for our internal lead.
Thank you.
Alice, 请说。
Can you hear me?
Yes.
Okay, I got a question for Sister Tiffany. I'm now work with DaVita Taiwan, and the DaVita company is an international company, and the headquarters is based on US. So I see you sharing your needle tapping, and I see the tap way is V-shaped and close to each other. And yes, and now And I'm a clinical service specialist in DaVita Taiwan. So our policy in needle tapping is we just do the V shape, but don't close to each other to prevent when we remove the tap, the sticky tap will harm patient. So we just do V shape for your reference.
Okay, thank you. Actually, our stand-up tapping method is shoving technique, but we also accept that the clinic then can modify the shoving technique to U-shape, because currently Taiwan use safety needle, and that's difficult when you have the crossover the tape up on the needle. When you want to remove it, sometimes it's difficult to remove.
Right.
And it will cause a little pain when you try to remove the needle.
Yeah, you have to force them and
yes,
hurt patient.
Yes. So we can accept that the clinic, that if they want to modify the shoving technique to U-shape, that is okay, because the aim is to have additional safety guard behind the wing, the needle wing, so then the needle will not easily be pulled out if any incident happen. So we can prevent needle dislodgement as much as we can.
Yes. Thank you. What type?
Okay, so any problems from our audience and speakers? Okay, please, Alice.
Yes, I have a question for Li Huacai. As your presentation, I see you assess the patient's point from 1 to 5. And I'm just wondering, how can you identify the percentage of the pulsation and SRIA? How can you identify? You use a monitor or just finger feeling to assess the point? Thank you.
I just finger feeling 10 seconds. Okay? And one by one training, everybody 20.
I'm just wondering, how can you? 我只是很好奇，说怎么样你们可以确定说，这个是50%，这个是100%，这个是75%，那只是凭借着手就可以确定它是不是有一些 standard 在里面，有一些 criteria。
当初学这个是跟阮仲和一位放射介入科医师学的，那他现在有更 advanced， 不过一开始学的时候，我们会就是临床的时候，我带人员的时候，我们一个人员最起码会训练大概20次以上，我们去达成一个共识。我们手指头去触摸的时候，一般我们医院的临床都说只有所谓的就是脉搏动跟震颤的这两个区别。可是实际上我在临床发现，当病人的那个瘘管有问题的时候，其实它是会并存的，而不是说你摸到只有说是震颤跟那个脉搏动，就是绝对这样子。那这样子我们去实验之后，我们每次大概就是会让人员每个训练20个人次以上，然后我们洗肾室的病人比较固定，所以我们这样子就会达到一个共识。这个病人摸起来这样子，大概10秒钟之后，我们会，譬如说我一开始轻触的时候，我可以很强烈的感觉到它就是震颤，没有脉搏动。那当我再往下压的时候，好，我可能等个1-2秒，那我会发现说我的病人的那个脉搏动可能会大于我的那个震颤。我们用这样子去做上下加减分这样，所以我们有达到一个共识。
好，謝謝。
Okay, thank you for our audience. Because time's up, and we will start our next session. Is discuss about the Steele syndrome. And it will be start since the 12:40. Thank you so much. See you later.